right, it's 8 a.m. Good morning, everybody. Welcome to Pediatric Grand Rounds. We have kind of a hybrid meeting today. It's very exciting. So I'm going to turn things over to Dr. Bell, who is with the Othello crew, to introduce our speaker and our lectureship for today. And just a reminder, if you have questions or comments and you are attending via WebEx, please make sure to add those into the chat and I will see them and share them with our speaker at the end of the hour. Thanks so much. I'm going to turn things over to the fabulous Dr. Shaquita Bell. Thanks.
Good morning. Thanks, Suzanne. I'm coming to you live from the best clinic in the whole world, right? Sorry to everyone online who doesn't have this level of energy this morning. I'm super excited to introduce this speaker. I have stalked her for several months. I'm not joking. Dr. Lisa Swartz-Tober attended college at the University of Pennsylvania and received her medical degree from Harvard Medical School in Boston. She completed her pediatrics residency through the Boston Combined Residency Program at Boston Children's and Boston Medical Center, and completed pediatric endocrinology fellowship through Boston Children's Hospital and Joslin Diabetes Center. Dr. Toper pursued additional training in clinical investigation at Harvard Medical School and Massachusetts Institute of Technology, also known as MIT. She serves as program director of pediatric endocrinology at Rhode Island and its Hasbro Children's Hospital, and is associate professor of pediatrics, a teaching scholar, and is at the Warren Alpert Medical School of Brown University. So I wanted to just let you all know why I stalked her. She was one of the lead authors on a paper that said this title in pediatrics. And I was just so impressed with the conversation around race-based medicine that I really wanted her to come and talk about this. So I'm super excited to have her. I have tried to recruit her, even though we don't have endocrinology at Odessa Brown. And she's very happy where she is at Brown. Sorry, Lisa, for all the stalking. But I'm really excited. And then for those of us at Othello, she is going to come back on after Grand Rounds and have some Q&A with us a little bit later in the morning. So make sure you keep your questions. And without further ado, Lisa, I'll let you take it away.
Thank you so much for that warm introduction. I'm really excited to be joining you guys. So it is it's such an honor to be able to speak with folks, and I hope to share some ideas and thoughts with you. And I really look forward to hearing your questions and your ideas at the end. So we're going to be talking about race and puberty today. And again, the title of my paper, and similarly the title of the talk, are Black Girls Undergoing Puberty at Younger Ages, and really thinking about race-based implications in how we have been teaching puberty and how to do that going forward, how to best teach and best care for our patients. So I don't have any disclosures. And for my objectives today, I'm going to be talking first about typical pubertal development, so we're all on the same page. I'm going to talk about the recent trends in pubertal development. And then I want one of our goals is to be able to recognize potential factors that contribute to these pubertal trends. And then finally, evaluating implications of race-based pubertal guidelines. So I'm going to start with a case briefly. So a 6-year-old girl comes into primary care clinic with concerns about early puberty. Breast development started at age 6 and has slowly progressed. She was born full term, appropriate weight, no complications. Maternal menarche was at age 12, so fairly average timing for mom's first period. And on exam, the girl has tanner 2 breasts. Her growth chart shows maybe a little bit of acceleration recently, but we don't have that much data. And so for anyone who's caring for kids in primary care clinic or any of the specialty clinics, this presentation is fairly typical and one that's seen kids with early puberty. So mom's worried that this child's going to have menarche soon. She's going to have her first period. That's mom's biggest worry. And what do we do next? So at this point, I want everyone to take a moment and either mentally note or jot down or type it on your phone, like what questions do you have? What to do next? What would be your thoughts if you were encountering this patient at any, in any sense, the things that you bring in your mind to this scenario. So just take a minute for that. All right. So since we're talking about puberty, I'm going to review the components of the reproductive axis. So the reproductive axis is activated by a network of gonadotropin-releasing hormone, or GnRH, neurons in the basal hypothalamus of the brain. GnRH stimulates pituitary secretion of LH and FSH, which then leads to production of gonadal steroids. Testicles will produce testosterone, ovaries will produce estradiol. Activation of the reproductive axis, which starts in puberty, is tightly controlled by the hypothalamus. And the hypothalamus is able to integrate multiple signals, internal and external signals, which impact pubertal timing. For example, metabolic cues must indicate if there's sufficient energy stores, and environmental cues must indicate favorable conditions for reproduction. And there's also a really strong genetic component to pubertal timing. So the reproductive axis has two very unique features. The first, which I represent with these little pulsatile graph of the GnRH and the LH and FSH neurons, is that GnRH must be released in a pulsatile fashion to stimulate the pituitary gland to also release LH and FSH in a pulsatile fashion. The pulsatility is what turns on either the ovary or the testis to produce their hormones. The second unusual feature of the hypothalamic pituitary gonadal axis is that it's active during gestation, it's active after birth during the mini puberty of infancy, and then there's a long period of active inhibition of GnRH secretion, which persists throughout all of childhood. So the system is inhibited throughout the younger ages, and then puberty is initiated when that pulsatile release of GnRH from the hypothalamus kicks on after this quiescent period. And what boggles my mind still, I've been an endocrinologist for many years, is that the precise mechanisms that trigger the initiation of puberty remain elusive. And like the way I think about this is like we can put people on the moon and we don't know what triggers puberty, which is just amazing and just shows for those of you who are trainees how much is unknown in the world of medicine and how much we still have to figure out. So when I'm thinking and talking about puberty, I'm talking about the progression today of cisgender puberty in girls. And what does that look like? It's the activation of the ovary, gonadarchy, and the first sign of puberty in girls is breast development. The next thing that we see is a growth spurt, and towards the end of puberty is when menarche happens. And you'll notice that pubic hair is not included in this list, as pubic hair development is driven by the rise in adrenal hormones or adrenarche, and that also starts in mid-childhood. But adrenarche is separate from central puberty, but because they occur around the same time, they're linked together as one process. So gonadarchy, again, the activation of ovaries to produce estrogen, first manifests with breast development or thelarchy, and then culminates in menarche, first period. Whereas adrenarche is the rise in adrenal androgens from the adrenal cortex, and it manifests with pubarchy, which is the development of pubic hair. And some examples that sort of make sense that they're separate is that there are patients who have ovarian insufficiency, who have normal adrenarche and have body odor and pubic hair and axillary hair, but they don't have any breast development and they don't have a first period. And then there's kids who have adrenal dysfunction and might not develop any pubic hair or axillary hair, but go through normal puberty and have breast development and a first period. So really the control of these are separate. And what I'm focusing on today is puberty, the central process from the gonads making estrogen. I've already mentioned that the first sign of puberty in girls is breast development. And so I'm going to just briefly go through the pattern or the trend, the progress of breast development with puberty. So Tanner staging is one way to sort of describe the different phases of breast development. Stage 1 is when there's no palpable breast tissue. Stage 2, which is again that first sign of puberty, is when there's a breast bud. And what is a breast bud? It means that there's breast tissue, but just underneath the areola or nipple. Once the breast tissue extends beyond the areola, even if it's just by a little bit, we call that stage 3. And then with more estrogen and more time, there's progression. The breast development changes. There's a difference in the contour of the nipple. And then stage 5 is a mature contour, mature shape of the breast. So again, the first sign of puberty is breast development. So what's the typical timing of puberty? So puberty is deemed physiologic when it begins between the ages of 8 and 12 years in girls. These are about 2.5 to 3 standard deviations below and above the mean age of onset of puberty as defined by population studies. The initiation of puberty at younger ages is called precocious puberty, and the initiation of puberty at later ages is delayed puberty. The study cited most often as defining the typical timing of puberty is a 1969 article published by Marshall and Tanner of Tanner Staging, that described 192 white British girls who were actually photographed every 3 months between the ages of 8 and 18. And then Tanner and Marshall looked at these photographs and studied how the breast contour changed and sort of figured out the mean timing of all of these different developmental phases of the breast, and again, from photographs. So in that study, the mean age of Tanner 2, that's breast bud development, was a little older than 11 years. This was pretty similar to earlier studies. A study from 1948 out of the Fels Institute in Ohio had a mean age of breast development of 10.8 years in 49 girls. Nearly 100 years ago, a study out of 250 girls in California had a mean onset of breast bud development of 10.6 years. And so that's the typical timing. And this progression is about 2.5 to 3 years from the beginning of puberty to the end. So there's usually about 2 to 2.5 years between the breast development and menarche. So when we think about pubertal timing, we know that genes are playing a big role. Genetics plays a big role. And that's why we ask about mom's age of menarche and about pubertal timing in the dad or other family members when we're evaluating a patient. Over the past 20 years, research in cohorts with familial forms of early puberty have helped us identify single gene mutations and help broaden the understanding of the genes involved in pubertal onset. So we've used these individual studies to learn about individual genes, but for the vast majority of patients, there's no particular gene or disorder involved in early puberty. And a lot of the patterns that we typically see is related to familial patterns. So when we think about early puberty, we're thinking about the turning on of that hypothalamic pituitary gonadal axis before age 8 years in girls. Leads to the production of estrogen, manifests with breast development. Now, the vast majority of cases of early puberty, so puberty before age 8 years in girls, is idiopathic. We find no particular reason why. However, because the role of that inhibition in the brain, the inhibition in the hypothalamus in keeping puberty quiet during childhood, any brain lesion, a tumor, significant trauma, seizure disorders, can lead to early puberty. And so as a result, brain MRI is part of the evaluation of children with early puberty. Boys are much more likely to have a pathological CNS lesion, so brain MRI is always a part of their evaluation. And for girls, it's really based on the clinical picture, whether or not we get a brain MRI for all girls with early puberty. So I've talked about puberty timing being after age 8 years in girls, but for anyone who takes care of kids, for anyone who's in pediatrics or family medicine and taking care of pediatric patients, they know that many girls are coming in with pubertal signs before age 8 years. So now I'm going to talk a little bit about trends in pubertal timing over the past few decades. So in a nutshell, puberty is starting earlier. This really came to light with a very significant article published in 1997. It was out of the Pediatric Research in Office Settings program, which looked at more than 17,000 girls from across more than 150 primary care practices across the United States. And what they found was that compared to norms from the 1960s and earlier, girls in the United States were starting puberty 6 months to 1.5 years earlier than the population means that were described just a generation ago. This was a practice-changing article in that it was identified as something that really changed how we think about our patients and influenced a lot of future study and assumptions about patient care. This is one of the main findings from the paper. So this graph shows the percentage of girls who have Tanner 2 breasts, so they've started puberty, and this is age. And I put in the blue line here at age 8, normal early timing of puberty. And what you could see, and this paper studied and separated patients by race, they have identified that 15.4 girls who are younger than age 8 have already started puberty, and 5% of girls identified as white in this study had already started puberty. And again, when I say a practice-changing article and high impact, as of last month, Google Scholar had identified more than 2,000 citations of this article. So following this publication, pediatricians and endocrinologists began to reconsider the normal timing of puberty. And so what happened was that in 1999, the Pediatric Endocrine Society, which is the largest organization of pediatric endocrinologists in North America, recommended new race-based criteria for defining precocious puberty. And though the guidelines were not formally accepted, the proposed recommendations, which were published in Pediatrics, stated that breast development should be considered precocious in Black girls younger than age 6 and white girls younger than age 7. Now, this 1997 article, written by Herman Giddens, was criticized, and one of the criticisms of it was that all of the pubertal staging was done by inspection, by looking at the breasts, not by palpation or feeling for a breast bud. And there was criticism of this because some girls, especially those who have elevated BMIs, might have tissue in the breast area that isn't necessarily breast tissue. So more work was done to figure out if these findings were really true or if it was just because it's the way it looked on exam, not how it felt on exam in terms of breast development. So the Breast Cancer and the Environment Research Program enrolled girls between the ages of 6 to 8 years from 3 areas in the country: San Francisco, Cincinnati, and New York City. And what they found was similar to the 1997 paper, that breast development was happening earlier. This graph, again, shows cumulative breast development up to Tanner stage 2. This here is age. The 1997 paper is the blue line, and it showed that even between the 16 years, between the 1997 publication and 2013, there was an earlier shift showing that the line moves to the left, that girls are beginning and undergoing puberty, transition to Tanner 2 breasts at an earlier age. And what this study also pointed out was that the girls who were overweight or obese, that's the green line, had an even earlier shifting of their pubertal timing. So they found that breast development was certainly earlier than the population studies described from the 1960s, that mean age of Tanner 2 breast development in this cohort was 9.6 years in non-Hispanic white participants. And here's the non-Hispanic Black participants. They found that Tanner 2 breast development was happening even earlier than the white participants in the study. And then they also showed a shifting to the left of the patients in the later study, meaning earlier pubertal onset, but especially those with elevated BMI. They had even earlier breast development. So BMI played the biggest role in the variance of pubertal onset in this study. So now we're seeing racial differences as well as BMI differences being reported in the literature. And because of this, race has become widely accepted as a factor in the pubertal timing of girls. So what do I mean when I say widely accepted? Well, in 2016, the American Academy of Pediatrics published a clinical report on the evaluation and referral of children with signs of early puberty. And in that report described the evaluation of girls with signs of early puberty has to take into account increased BMI as well as race ethnicity. In 2019, the Pediatric Endocrine Society guidelines were published after an international consortium developed it. This is on the use of gonadotropin-releasing hormone analogs in children. Those are puberty blockers that we use to halt early puberty. And in this report, they described, since patients from African American and Hispanic racial and ethnic groups have an earlier normal range of onset of puberty, different age criteria should be considered when diagnosing central precocious puberty. So basically saying these groups are different, their normal timing of puberty is different, and therefore we should define precocious puberty differently. So in addition to scientific publications, race is often included in patient resources about puberty. So if you're a worried parent and you Google what is the typical timing of pubertal onset, you might find a patient information page, such as this one from Cleveland Clinic, which describes Black and Hispanic girls tend to start puberty earlier than white girls. Or you might find something like this. This is from Mayo Clinic patient information page, which under risk factors for early puberty describe being African American, because it says precocious puberty appears to affect African Americans more than children of other races. So as a result of all of this, many patients, caregivers, medical students, physicians, and other health professionals have been taught that Black girls experience puberty at early ages. However, race is a historically derived social construct that has no place as a biologic proxy. Race as a social construct doesn't represent shared genetic ancestry. It is instead a way of categorizing people on the basis of physical characteristics. Additionally, race as a category wasn't ever well defined, so belonging in a particular race has never been stable and has always been subjective. So because of this, it really, in thinking about all of this information I just presented to you on puberty, and this idea that race is this big factor in it, there's really a disconnect. It makes it sort of, we need to take pause here and think what's going on? Why are we seeing this? The research is true. They're showing these changes that are happening to all of our patients and affecting some groups more than others, but not because of a biological difference between races. So I want to pivot for a moment and bring up a table from a New England Journal of Medicine article published in 2021 that focused on misrepresentation of race in medical education. But I think that the ideas and themes are really helpful for us to think about misrepresentation of race in any aspect of what we do in the health professions. So I'm going to go through these different domains and the examples. So one example is semantics. So this is the idea of using imprecise and non-biological labels that inaccurately conflate race and ancestry. So widespread use of Caucasian, Black, African American as labels to denote biological differences between patients, when in fact they're not biological labels. Then we have prevalence without context. This is the idea of presenting racial or ethnic differences in disease burden, but not giving the appropriate background. So a classic example is teaching students that Black patients have higher rates of asthma than white patients, but not talking about the effects on asthma prevalence of residential segregation or unequal access to high quality housing or healthcare. We have race-based diagnostic bias, and this is the linking of racial groups to certain diseases. And again, the classic example is teaching that sickle cell disease affects only Black people, as opposed to thinking of it as a disease that affects populations that are at risk for malaria. Then we have pathologizing race. That's the tendency to link minorities with increased disease burden. An example they used in this article was a slide describing that incident rates of a certain type of tumor are higher in Blacks than whites, when in fact, the majority of the tumors were actually occurred more frequently in white patients. And then finally, the use of race-based clinical guidelines. So that's teaching guidelines that endorse racial categories in the diagnosis and treatment of disease. And an example is that students are taught that a first-line antihypertensive medication that is ideal for Black patients is different than what's the right medicine for white patients. And doing that without any background about the literature that questions these practices and what interpretations of the original data led to these beliefs. So with this background, I want to now bring us to the ways in which race has been misrepresented in the thinking and teaching about puberty over the past 25 plus years. So the downward trend in timing of breast development has been described all over the world. This is Tanner 2 breast. We have year of study. And in the United States, in a number of European countries, there has been a downward timing from all over the world in the onset of breast development. So why? What changed? And what's continuing to change? Because we're still seeing this downward trend. And then more specifically, what factors are driving these observed racial differences in the timing of breast onset? What's race being used as a proxy for? And what are the social and structural contributors to disease? So thinking about the potential influences on pubertal timing, we're going to think about the social determinants of health and the impact on pubertal timing. Think about nutrition and obesity, environmental exposures, and early life stress as examples. So first, obesity trends. Again, I'm speaking to pediatricians here and other folks who are caring and involved in taking care of our youngest patients. And everyone has seen the graphs and tables showing that the trends in obesity in the United States from coast to coast is showing that it's rising. This is national data looking at the percentage of children with obesity. The dark blue line is our youngest children. The light green line is our oldest teens. Everyone is showing rises in rates of obesity. And so overweight and obesity are associated with the earlier timing of puberty in girls. So it's definitely one of the factors. And the earlier shifts in pubertal timing corresponds with a rise in obesity. There are also disparities in obesity rates. 2018 data, so again, pre-pandemic, looking at non-Hispanic white girls reported about 15% of girls with obesity, whereas approaching 30% of non-Hispanic Black girls. And this again was from a national cohort. So how does this fit in? So with obesity, we have food insecurity and lower socioeconomic status both affect obesity rates in youth. Those are both influenced by geographic inequality. So geographic inequality increases the risk of obesity because areas that don't have access to good nutrition in terms of fresh foods, supermarkets, we have food deserts where it's really hard to find good food. And then we have food swamps, high concentrations of processed and fast foods. You know, the sort of trend of the dollar stores moving into a lot of neighborhoods, giving ultra processed foods at low prices really provides suboptimal calories to a lot of our most vulnerable patients. And then areas that are experiencing geographic inequality are often the same areas that have lack of green space and playgrounds. So when I'm talking about geographic inequality, how does that tie into race? Well, it's a form of environmental racism, which is the disproportionate exposure to and impact of environmental hazards on minority populations. So this is a map from the University of Washington website. It's from 1936, and it is a map that outlines what was labeled, if you can see faintly here, hazardous is the red. So in the 1930s, the federal government developed a program to guide banks as to which neighborhoods would be the right neighborhoods to give mortgages to. And they drew red lines, the policy was called redlining, around neighborhoods that were more hazardous, the neighborhoods often where minority populations lived, were the neighborhoods not to invest in, not to give money to, not to loan mortgages to. And as a result, this was basically a legal form of residential segregation, and it led to neighborhoods that thrived and neighborhoods that did not have resources. And this led to lack of good housing opportunities, limited community resources like parks, grocery stores. And these communities were often then targeted for being near to waste facilities, heavily trafficked highways. And so because the minority and low-income neighborhoods, this legacy of redlining, again, from the 1930s, still impacting us, today, these neighborhoods are often the ones that have the greatest exposures to contaminants in the air, in the soil, in the water. And those exposures, it can increase the exposure to endocrine disrupting chemicals. So what are endocrine disrupting chemicals? They're any chemical that interferes with the synthesis, secretion, transport, binding, action, elimination of a natural or endogenous hormone. So in the box here on the left, the green diamond is a normal hormone. It binds to its yellow hormone receptor, and then there's a downstream cellular response. If you have an endocrine disrupting chemical that mimics the hormone, purple diamond, it can bind to the hormone receptor even in the absence of the actual hormone being present and lead to this cellular response happening even without the hormone being there. And then other endocrine disrupting chemicals might act as blockers. They can bind to the receptor, but they don't trigger the downstream response. So the cellular response doesn't happen. Now, endocrine disrupting chemicals, unfortunately, are ubiquitous in the environment. But when we're talking about puberty, they can act on all parts of the body and development of the body, but particularly the fetal brain is extremely vulnerable. And if you recall earlier, I talked about how the hypothalamic pituitary gonadal axis is active in fetal life and in early postnatal life. And those are really critical times. So it's a time of special vulnerability to environmental exposures, including endocrine disrupting chemicals. And the timing of pubertal onset being triggered by reactivation of the hypothalamic pituitary gonadal axis might also be susceptible to disturbance by endocrine disrupting chemicals. So we have the general idea of endocrine disrupting chemicals in the environment and environments that are more at risk for that. Then we also have endocrine disrupting chemicals that can be found in personal care products. So environmental racism also includes the disproportionate exposure to harmful chemicals in personal care products marketed to communities of color. Black or African American women in research studies have been identified to have high rates of hair product use and duration, which is increased exposure to hormonally active chemicals and endocrine disrupting chemicals. A study that looked at the Greater New York hair products cohort identified 6 commonly used hair products used by Black or African American women. And when I say commonly used, it was being used by more than 10% of the women who participated in the study. And they found that they all affected hormonal activity in reporter gene assays. And use of hair products might not always feel like a personal choice. There are workplace examples of natural hair discrimination as a form of racism. And so since appearances can lead to very material consequences, it can put patients and their families in very difficult positions about using products, even if they are potentially harmful because of the impact of what natural hair discrimination, what their experiences might be with that. Another study out of New York it was a retrospective study and a small study, 300 New York City women. And they collected information both about their age of menarche as well as different hair product use. And they found a association between the earlier age of menarche and more hair product use in childhood. Most of the research in girls has looked at one of the particular categories of chemicals, phthalate exposures. And the strongest evidence was with one particular phthalate called monoethyl phthalate. Was associated with earlier puberty and earlier menarche. Other associations looking at different endocrine disrupting chemicals were small, some had conflicting findings, and it's certainly an area that needs more research. This article caught my eye. This was published both in the literature and then picked up in the New York Times last winter, so December 2022. And it was a long-term follow-up study of more than 30,000 women, so huge numbers. And they found that hair straightening products was associated with higher incident uterine cancer studies. And so they found this was strongest when they compared the women who used hair straighteners most frequently compared to the never users. They found the hazard ratio was more than 2.5 times greater in the frequent users of hair straightening products. And this was specifically for uterine cancer. But other studies have looked at other hormone-sensitive cancers, including breast and ovarian cancers, and have also found these positive associations with hair care products. So again, not just something that's affecting potentially our youngest of patients, but potentially patients across the lifespan. And when I said earlier that endocrine disrupting chemicals are ubiquitous, they really are. There are a lot of different families of endocrine disrupting chemicals. Bisphenols, bisphenol A, that's the one that was in the lining of our canned goods. They're also in plasticizers and other drink and food containers, and that has been shown to be estrogenic and bind to estrogen receptors. Phthalates, again, that one category was associated with earlier puberty. Pesticides, they are in our agricultural products and can have endocrine disrupting effects. Parabens, which are in cosmetics, flame retardants, and so on. So these chemicals are everywhere. But I think being aware of them and being aware of potentially what they could be doing to all of us, and especially thinking about our patients who are most at risk, our youngest patients, and those who have the highest rates of exposures. I'm going to pivot now and talk about early life stress and pubertal timing. So the weathering hypothesis was developed by Geronimus in 1992, and she speculated that the cumulative effects of social, economic, and political adversity fueled the early health deterioration of Black women. And so taking this idea of this stress and how it might impact health, looking at early childhood stress and puberty have found some positive associations between different forms of childhood stress and earlier menarche or earlier puberty. One example, a large study out of California looked at more than 20,000 kids, and they found that girls who did not live with both parents either before the age of 2 or between the ages of 2 and 6 were at higher risk for early breast development compared to those who lived with both parents until at least age 6 years of age. And in this study, they used a single parent household as being an indicator of stress, where it might not be in all cases, but certainly a concern showing that the impact of the home environment is impacting pubertal timing. These phenomena are not just unique to the United States. A study in Australia looking at 3,500 children, and they looked at what they called family socioeconomic position, which was a parental report of income, education, and occupational prestige. And what they found was that cumulative exposure to the most unfavorable household, that's the khaki color here, in girls was an independent predictor of a twofold increase of early puberty compared to the most favorable group in orange. So this early childhood stress was associated again with early pubertal onset in girls, and they found the same association even stronger in boys. Back to the United States, a very recent study published just last month looked at a longitudinal study of 45,000 girls in Northern California. And this looked at the index of concentration at the extremes. The index of concentration at the extremes is a way to measure social polarization by quantifying extremes of the most deprived and the most privileged groups by looking at as a single metric. And this has been shown to partially explain racial disparities in other types of work, such as the differences in preterm birth and infant mortality. And what this study found was that compared to the girls born into the neighborhoods of the most privilege, the one born into neighborhoods with the most disadvantage were more likely to experience puberty at younger ages. And they found that the harmful effects of the disparities operated independently of the socially constructed race and ethnicity. So, showing that there's a role here of structural racism that was perpetuating these disparities, not race as an explainer of the differences. And then finally, a study on the East Coast, a smaller study looking at 500 kids, this was published last year, showed that greater neighborhood disadvantage was associated with faster pubertal development. What this study considered for neighborhood disadvantage was educational opportunity, health and environmental opportunity, and social and economic opportunity of the neighborhood. And they found that, again, that the greater disadvantage was associated with early pubertal development, as well as greater risk of obesity. And these authors, they interestingly concluded that the increased stress with living in this disadvantaged environment might accelerate biological processes and neurodevelopment, including reproductive functioning, as if the life is so stressful, we need to get a move on it and move forward with our development and get life going. And again, these are just hypotheses, but the observations are real. So all of this discussion, what about the impact of this? What about the impact of early puberty on Black girls? And what could we as providers do about it? So first, we have race pathologization, the idea that racial health disparities exist because of biological differences between groups. This is, attributing poor health outcomes to an individual race. It perpetuates false ideas that health disparities are due to biological differences. And, most heartbreaking as a pediatric provider is it's teaching families and children that their race, for some reason, is a risk factor for poor health outcomes. And instead, in working towards health equity, it's essential to recognize that the burden of disease affects certain racial groups more than others, and to acknowledge the roles of institutional and structural racism in fueling these health inequities when identifying the disparities. And really helping our patients avoid a sense of fault, because it's not their fault at all. Adultification bias. So this is a form of racial prejudice in which Black children are treated and judged as more mature than others of the same age. And this has implications across social structures, both in terms of the juvenile justice system, in terms of school punishment. We also have that earlier development might lead our young patients to greater risk of unwanted sexual advances. Very significant and things that need to be addressed and counseled for appropriately. The idea that, in medical school, I learned, Black girls underwent puberty at an earlier time, just as a fact. And this could lead to suboptimal patient care if we accept that as a fact. We can, race-based medicine and these guidelines, can lead to withholding of appropriate care. We might fail to ask appropriate questions. We might fail to give the appropriate counseling or unmask underlying diagnoses. It also leads to lack of questioning. It halts intellectual curiosity if we think something is and we don't ask why it is. What I've noticed is that over the past few years, there's been a lot more work in terms of disparities and the relationship to early puberty. But it's been only in the last few years, after a few decades without it. Another impact, the longer duration of estrogen exposure. So girls with precocious puberty have longer estrogen exposure than girls with typical pubertal development, and estrogen exposure is associated with developing future health risks like estrogen-dependent cancers, obesity, and type 2 diabetes. And finally, early puberty can make kids more likely to participate in risk-taking behaviors. So again, something else that could be a target for how we counsel our patients. So throughout the last number of slides I've gone through, I've talked about a number of different ways in which different events in early childhood can impact pubertal development. And I want to circle back to the idea of misrepresentation of race in the discourse of early puberty. And bringing back up this slide from earlier, so this is again from New England Journal 2021, the idea of misrepresentation of race in medical education, but now I'm going to specifically go through it in terms of puberty. So misrepresentation of race in the discourse about puberty. So for semantics, the idea of Black and African American as labels as if they were to denote biological differences between research subjects. If you remember back, I described in the very beginning, one of the second study, the one in 2013, the breast cancer environment research program. That was the follow-up study that used palpation of the breast to do Tanner staging. In the article, they described how they categorized patients. And what they described was that if girls identified as more than one race, then Black superseded all other races. And then if patient identified as Hispanic and another race, if they didn't identify Black as well, then Hispanic superseded other races. So these labels don't tell us anything about biology. They're telling us about a social category, or they're telling us about melanin in the skin, but it doesn't give us anything about biology. We have prevalence without context. This is the idea of teaching that Black girls are more likely to have early onset of puberty, but not talking about the effects of nutrition, of obesity, of the environment, of endocrine disrupting chemicals, of stress, and of things that I haven't included that are playing roles in our children's development. We have race-based diagnostic bias. So this is focusing on early puberty in Black girls as opposed to an outcome of a myriad of factors, including those driven by racism. We have pathologizing race, and this is listing African American as a risk factor for precocious puberty. And then we have race-based clinical guidelines, proposing different age criteria for the diagnosis of precocious puberty in Black girls compared to white girls without consideration of why differences are seen in these population studies. So this next figure, so I found a similar figure. It was in an article published last year about endocrine disrupting chemicals in breast cancer, but I adapted it because I thought it fit really well to some of the themes discussed today. So when thinking about disparities in pubertal onset, let's start with structural and institutional inequities. We have discriminatory housing policies and the legacy of redlining, lack of access to optimal nutrition, early life stress, and racism. That leads to unequal exposure to contaminants, living near hazardous sites, food packaging, personal care products, and those that we haven't identified yet, leading to activation of biological mechanisms, endocrine disrupting chemicals at hormone receptors, adiposity signals, and again, the things we haven't figured out. And finally, gaps in research and care, insufficient research into racial disparities, potential to miss pathological causes of early puberty, health consequences of early puberty, race pathologization, and again, the pieces I haven't thought of. Just shows how much work there is to do. So bringing us back to that case I started with. So a 6-year-old girl with early breast development. Looking back now, after the last 30 minutes of what I've talked about, when you think about this 6-year-old girl with breast development, what are some of the questions and approaches to patient care that might be a little bit different than what you first thought of? So I want you to bring that with you, and with each patient encounter, think of some of these points. So what next? So at a population level, I think the best approach is to just be aware and start recognizing race-based medicine when you see it, whether it's in a classroom, whether it's in a textbook, whether it's at the bedside with patient care. Looking into the research or getting involved in it, or the advocacy work. And if you're interested in starting somewhere, the American Academy of Pediatrics published a nice piece last summer in Pediatrics on eliminating race-based medicine. And what they described as a starting point, we need transparent recognition, declared opposition, and active replacement of race-based medicine. At a community level, I think addressing the risk factors for obesity will make a great difference for many of our patients, increasing green space, optimizing nutritional offerings, and again, for everyone, advocating for decreased use of endocrine disrupting chemicals. And then on an individual level, for our patient at the bedside, really providing age-appropriate counseling and anticipatory guidance about what to expect in terms of early pubertal development, counseling to reduce exposures to potential endocrine disrupting chemicals in personal care products whenever possible, and most importantly, individualizing care rather than categorizing care based on race. I think part of that is also avoid having parents and or caregivers and children come away with feeling like they're being blamed or they're at fault, and really trying to provide the best care for the patient in front of you. So thank you for your attention, and I'm really excited to hear some questions. I want to also acknowledge my colleagues who I worked with on some of this work. First, Ade Osunubi. She is a PGY1 emergency medicine resident at Penn and a former Brown medical student who was instrumental in the excitement and the work that we did together on this. It was through her work on the wards with Dr. Paula Lewis de Los Angeles, who's a triple board resident, now a PGY4 at Hasbro Children's Hospital and Rhode Island Hospital. And then Dr. Poitevin is our Senior Associate Dean for Diversity, Equity, and Inclusion and our former PEDS Residency Director. And she was also really wonderful to work with on this. And so with that, I look forward to hearing your questions. Thanks for your attention, everyone.
Hi, I had a
Yay! I
quick
couldn't unmute
question.
for a second. Go ahead. Go ahead.
Our question from Seattle Children's Auditorium, at least mine, was what would be the next practical thing to do for the kid that you saw, like the 6-year-old, as if you see them in the outpatient clinic? Would you recommend that we advise, draw labs, send them directly to endocrinology kind of thing?
It's a great question, and I'm guessing that you see a lot of patients, because again, we're seeing a lot of 6 and 7-year-olds with early puberty. I think first figuring out what's going on. Is it true breast development? Is there pubic hair? Like sort of what picture of where are we in the development? And then I think, often a bone age is a helpful starting point, and seeing, bone age is a really good integrated assessment of the amount of sex steroid that you've been exposed to. And so that can often give a clue as to sort of how much and how long has this been going on for. I think with most 6-year-olds, I would say, endocrine evaluation is warranted. I think as you get towards 7 years, 10 months, with 8 being our cutoff, if they come in with 10 or 2 breasts at 7 years, 10 months, I think, in that case, it's also in the context of the family. If mom had menarche at 9 and grandma had menarche at 9 and the sister had menarche at 9 and the kid comes in with breasts at 7.5, that's probably just on target with the family. If it's very different than that, if it's the kid is, the family all had later bloomers and the child is younger, that one might sort of require a more thorough look. But I think, what I'm not including, what I didn't include in the slides at all, is what was the race of this child, which I don't, should not play a role in our at the bedside assessment of the patient and what's going on. The other piece to look for when we see early puberty is, are there any CNS symptoms? Does the child have a history of any, CNS disease? Is the child having headaches? Is there any concerns about growth patterns, things like that? So it's all taken in context. But I think 6-year-olds, for me as an endocrinologist, I'm always happy to see a 6-year-old with puberty.
Thank you.
Thank you. I'm not sure if there are any more questions in write, but there's a few in the chat, so I'll just go ahead with those if that's okay. And then Emily, you can interrupt or you can take over, and then I'll give things over to Dr. Bell, because I know there's a lot of people in Othello. From Danielle Lewis, how does exogenous or added hormones in dairy and meat production factor into early puberty? Is access to organic dairy and meat protective against early puberty, tying into food deserts and swamps?
Oh, it's a great question. So dairy's been looked at pretty thoroughly because that was definitely a great source of concern. And there's been no signals that dairy products, with or without hormones added to them, has been related at all to early pubertal onset. The other question that usually comes along is soy. And similarly, soy has been looked at really thoroughly. And if you think about the parts of the world that eat the most soy products, which is typically in Asia, that is not the part of the world leading the way in early pubertal development. So I think these are great questions in terms of asking about it. And I think it's not the native food supply, it's the what's added to our food supply. That's always the part in question. But nothing, nothing has come out yet in terms of I have parents asking me all the time, and I'm a mother of 2 kids as well. And I knew it. I always tell the families, if I knew what it was, I would tell you what to eat or not to eat. But, really trying to, not have people be afraid of the food, especially if access to food is limited. But really, we haven't seen anything. And again, dairy hasn't shown up as the thing, even the modern dairy that has whatever's added to it.
Thank you. And I'll just point out to those of you who aren't looking at the chat constantly that there are some endocrine clinic referral guidelines pertaining to the first question, and they're linked in our chat. But basically, I think the bottom line is endocrine does have referral guidelines for when they want to see patients with precocious puberty signs. And now I'll turn things over to the others with microphones. So Dr. Bell, if you have people with questions in the big room that you're in, or if there's anything left in right auditorium. Thanks so much. I will be quiet and let others ask questions. Thank you.
Thanks so much, Lisa. That was really, really good. I was getting a lot of text messages. I think hopefully people held on through the medical introduction. We actually have some set aside time for questions. So I think I'm going to pass because Lisa's going to take a break and come back and join us, Suzanne. So if there's anything else in the chat or in the auditorium, I think we should go with those folks because selfishly we have our own time with her.
Got it. I'm not sure. I might need clarification on this question from Kelly Fassett. How might these factors play in gender related issues? I might need some clarification, Kelly, or you can unmute and ask your question.
So I'm driving, so it's a little hard. But there's been so much gender dysphoria, and a lot of things have changed in the last many years. So I wonder environmentally if these factors could be contributing to that.
I mean, that's a great question, and honestly, something I've never thought of. And I haven't even looked in the literature to that. I think what struck me, which sort of is a bigger theme than what you're asking, but certainly the answer is yes. In that the environmental exposures to these chemicals, I mean, it's a scary place to go in terms of reading the literature once you see what these chemicals are and where they are. So I don't know if it's playing any role in gender dysphoria at all. But in terms of being something that every single person that you encounter in the world is exposed to at greater levels now than it was 30 years ago, that's certainly the case. But now I'm going to go look and see if I could find anything in the literature to answer your question.
Thank you so much. And thank you,
Thank
Kelly,
you.
for clarifying. Clarifying while driving. Thanks. I don't have any more questions in the chat right now, and I'll just ask the auditorium if there are any other questions, and then we can let you take your break because I know you have more time with the Othello crew. All right, not hearing anything or seeing anything. I think we'll turn the screen over to our evaluation screen. For those of you who can see the screen, please submit an evaluation for us. It helps our Grand Rounds Planning Committee for future Grand Rounds. Thank you so much, Dr. Bell and Dr. Topor, for your expertise, and Dr. Bell for stalking and finding Lisa to speak to us today. And I will let everybody go from Grand Rounds, and we'll see you all next week, Grand Rounds people, and then Othello people, enjoy your next hour. And Dr. Topor, take a little break. Thanks so much, everybody.
Okay, team. I don't know. Can they still hear me, Joe?
We can hear you.
I'm talking to my team. Sorry, Suzanne. You guys can jump off.
Thanks everybody for joining us today. Thank you, Lisa. That was excellent.
No problem. I just saw something pop up in the chat though, and just want to clarify. I don't know what was the specific question, but certainly no gender dysphoria not being a disease at all. But it's something I have not ever considered endocrine disrupting chemicals as something that could be playing a role at all. So I'm gonna look in the literature at that.
Thank you, Team 3, for that clarification as well.
All right. Thank you so much.
All right. Thanks, everybody. We'll see you all next week for Grand Rounds. We really appreciate everybody's time. Thanks so much.